Ceftriaxone, a go-to antibiotic in hospitals worldwide. It can sometimes cause serious and even life-threatening reactions, especially in newborns. But why does a drug that saves lives sometimes cause harm? Let's explore the pharmacologic mechanisms behind its adverse effects. Welcome to our pharmacology series. Today we'll discuss ceftriaxone, a third-generation cephalosporin antibiotic, widely used for serious infections like pneumonia, meningitis, and sepsis. But alongside its effectiveness, ceftriaxone carries important adverse reactions and precautions that every clinician should understand. We'll walk through each one and explain the underlying mechanisms. The following are significant adverse reactions caused by ceftriaxone. Ceftriaxone calcium precipitation. Ceftriaxone can form precipitates, or solid particles, when combined with calcium, leading to serious damage, especially in newborns. In some premature and term neonates, this has resulted in fatal lung and kidney injury due to the accumulation of these calcium ceftriaxone complexes. Newborns are highly susceptible due to immature organ function, a longer drug half-life, and competition for plasma albumin binding sites. This reaction can also cause urinary sludge, which refers to suspended particles in urine due to excess calcium crystals. Kidney stones. Urolithiasis, which means having stones in the urinary tract. Acute renal failure, which is a sudden decrease in kidney function, leading to the inability to filter waste from the blood. In the gallbladder, ceftriaxone can cause thickening of bile and even gallstones. Sometimes, these lead to pancreatitis, which is inflammation of the pancreas caused by blockage of the bile duct. Mechanism of these reactions is due to insoluble precipitates formed that can block bile ducts or kidney tubules. Risk factors include pediatric patients, especially 12 to 24 months old, high doses of ceftriaxone, more than 2 grams, prolonged therapy over 5 days, impaired gallbladder emptying, and biliary stasis, whereby bile flow slows down, such as after surgery or during severe illness. Second significant adverse reaction is Clostridioides difficile infection. This is one of the well-known antibiotic-associated complications. Clostridioides difficile is a bacterium that overgrows when normal gut bacteria are wiped out by antibiotics, causing severe diarrhea and inflammation of the colon known as colitis. Symptoms can appear during antibiotic therapy, or up to 3 months after stopping the drug. Risk factors include antibiotic exposure, especially third and fourth generation cephalosporins, hospital stays or recent healthcare exposure, older adults, immunocompromised patients, those with weakened immune systems, serious underlying illness, GI surgery or procedures, anti-ulcer medications such as proton pump inhibitors and H2 blockers, which reduce stomach acid and allow bad bacteria to survive, and chemotherapy. Another significant adverse reaction is hemolytic anemia. Ceftriaxone has been associated with immune hemolytic anemia, which means the immune system destroys the body's own red blood cells. Mechanism behind is non-dose-related and immunologic, whereby the drug triggers antibodies, mainly of the IgM type, that activate the complement system, forming immune complexes that break down red blood cells. Risk factors include pediatric patients, sickle cell disease, and cross-reactivity with other cephalosporins, which means allergic response to one cephalosporin causes a reaction to other cephalosporins with a similar structure. Ceftriaxone can cause both immediate and delayed hypersensitivity reactions. Immediate reactions are allergic responses that happen quickly within 1 to 6 hours, like urticaria, commonly known as hives, which is characterized by raised, itchy welts that can appear anywhere on the body. Anaphylaxis, which is a life-threatening systemic allergic reaction. Anaphylactic shock, which is when anaphylaxis causes dangerously low blood pressure. Delayed reactions include maculopapular rash, consisting of 2 types of lesions, flat red spots and small raised bumps. Maculopapular reactions occur 7 to 10 days after initiation. Other reactions appear after 7 to 14 days up to 3 months, including severe cutaneous adverse reactions, scars in short. Examples are acute generalized exanthematous pustulosis, drug reaction with eosinophilia and systemic symptoms, Stevens-Johnson syndrome, and toxic epidermal necrolysis. Immediate reactions are mediated by IgE antibodies, while delayed ones are T-cell-mediated immune responses. Here is something to note on issue of cross-reactivity. Good news is, Ceftriaxone has negligible cross-reactivity with penicillins due to different side chains, making it relatively safe in penicillin-allergic patients. Another important adverse effect is kernicterus. Ceftriaxone can cause kernicterus in neonates, a type of brain injury caused by high unconjugated bilirubin levels. Normally, bilirubin, a yellow pigment from red cell breakdown, binds to albumin, a plasma protein which keeps it from crossing into the brain. Ceftriaxone displaces bilirubin from albumin, increasing the amount of free bilirubin, which can cross the blood-brain barrier and deposit in brain tissue, leading to kernicterus. The symptoms of kernicterus can appear in stages and may be preceded by severe jaundice, which causes yellowing of the skin and eyes. High-risk groups are neonates, especially premature, and hyperbilirubinemic infants, those with high bilirubin. Let's now organize the adverse effects by frequency. We have common ones which are more than 10%. Here is the list. We have less common, which are 1 to 10%. We have rare ones, which are less than 1%. Now let's see contraindications. Ceftriaxone should not be used in anyone with known hypersensitivity to ceftriaxone or other cephalosporins, hyperbilirubinemic neonates, due to risk of kernicterus, premature infants, less than 41 weeks post-menstrual age. This is the total time elapsed from conception to the present. It is calculated by adding a baby's gestational age, time from last menstrual period to birth, and their chronological age, time since birth. Other contraindications are neonates receiving intravenous calcium-containing solutions and intravenous formulations containing lidocaine. Now let's finish up with precautions. Ceftriaxone can increase INR, International Normalized Ratio, a blood clotting measure, especially in malnourished patients or those with liver or kidney disease. This will cause blood to clot more slowly than normal, which increases risk of bleeding. INR should be monitored closely, and vitamin K supplements should be given when needed. Superinfection. Long-term use can cause secondary infections like fungal overgrowth. Patients with concurrent hepatic dysfunction and severe kidney disease, dosing adjustments may be recommended since ceftriaxone is cleared through both routes. So that's ceftriaxone, a powerful antibiotic that demands careful use. If this video helped clarify the pharmacologic concepts, hit subscribe for more detailed breakdowns in pharmacology and therapeutics.